Hi, everybody. Hope you can hear this. This is Professor Wheeler. We're going to be going quickly through the genetics section of our after exam 3 information. So I'm going to say this once. I'm going to say this a million times. Focus on, for the genetics, what is in the PowerPoint. If it's not in the PowerPoint, you don't have to focus on it. So again, focus on the PowerPoint. Focus on the PowerPoint. Don't go off of the text. PowerPoint. All right. So things that you need to know for the genetics portion of this exam. Mutations and disorders to know. So I have five terms up on the board. These are the 5 that you need to know because these are the 5 that you are going to see time and time and time again when you are working as a nurse in regards to genetics. So our first one is the germline mutation. It's also gerline is the other way that it's said, or congenital is the other term. And these are ones that are present at birth. So any cell of a person that has a germline mutation is going to have the same mutation across all of the cells. It doesn't matter if it's a skin cell, it doesn't matter if it's an embryo cell, it doesn't matter if it's a muscle cell, doesn't matter because the DNA that is in all of our cells is always the same. And the mutation happened at the formation during conception and fetal growth. So it's going to be present in all of our cells. Versus an acquired mutation. An acquired mutation happens over the course of our lifetime. So from extrauterine life onward. And this happens because as cells multiply and grow and replace themselves, they copy their DNA. Nothing's perfect, life happens. Sometimes there's a breakdown of that genetic code where a gene will read differently and thus we see a mutation happen. Because this mutation is based in the cellular section that it's in, it is not passed to the next generation unless that section that it's in happens to be either the sperm cell or the egg cell. So in a great example of an acquired mutation, specifically from an environmental mutation or manipulation, is skin cancer being caused by UV light. UV light does not, it happens in the world. It passing into our body breaks apart part of the cellular structure of the skin DNA, which causes it to replicate at way too fast of a level, giving us skin cancer. So those are the 2 types of mutations that we can have. Either you have it at birth and it's all the way across, or it happens during the lifetime. Now, the 3 types of disorders that we have single gene disorders, chromosomal disorders, and multifactorial inherited conditions. So a single gene disorder, this is one gene malfunctioned across the entirety of the body where we see very systemic involvement. For example, cystic fibrosis and sickle cell disease. Specifically, remember when we're learning about cystic fibrosis, it mainly affects the lungs and the pancreas. So as soon as there's 2 different body parts, that is something similar that we see with all single gene disorders. So again, if I have mentioned that sickle cell and cystic fibrosis are single gene disorders, know that correlation between the 2, don't go much further than that. For chromosome disorders, so our DNA breaks into chromosomes when it is time to mutate. So for example, a disorder that comes from a chromosome, specifically having an extra set of chromosome 21, is Down syndrome, which occurs, it's something that we can see from birth, and it's based on those chromosomes. And specifically, the medical term that you would also see other than Down syndrome is trisomy 21. Tri meaning 3, so 3 copies of chromosome 21. And the last thing is multifactorial inherited conditions. So a multifactorial inherited condition is a genetic predisposition towards a condition occurring. So for your example for this one is BRCA1 and BRCA2. BRCA1 and BRCA2, if that gene is present in a patient's genetic makeup, it highly predetermines them to have breast cancer. So if someone already has a high risk of breast cancer and has the BRCA1 gene, we will sometimes preemptively suggest that they have a mastectomy to reduce the likelihood of them having that condition occur. So next, when do we use genetics in nursing? 6 cases in which we will use genetics as nurses. Are you going to see genetics more in certain specialties of nursing? Yes. If you are working in primary care or life medicine, so women and children's health, you are going to see more genetics than if you worked in the ICU or the ER or the OR, for example. So sometimes that we may see genetics. We will see genetics give us a really good predictor for what is going to happen over the course of someone's lifetime. So you see us using genetics before a fetus, as a fetus grows, and right during that understanding and the growth, the major growth cycle. So that's the prenatal testing. You see it very early in neonates, which is the ante or the postnatal testing, which is the predictive on this screen, which is the probability of a occurrence of a disease. And then you see it as diseases progress more in the diagnostic testing to rule in or rule out specific conditions. Other times that you'll see it specifically, relatively recently, we've started something called bionic or biogenic medications. And that is looking at a person's genetic code and determining where in their genetic code would a medication be able to be its most effective. So about 5 years ago, there was a big campaign for if somebody had been unsuccessful in finding a antidepressive medication that worked, we would actually have them do a cheek swab, and we would look at their genetics to see what brand of medication would work better for this patient. So that's your pharmacogenetics, which is blending medications, so the pharmacology with the genetics to make it work for patients better. Our last 2 on this sheet, forensic or paternal genetics is used specifically in a genetic or a sane nursing environment to determine the genetic makeup of either a person who has been found without other identification, or to identify trace DNA left behind. And last is a carrier screening. So a carrier screening is really helpful for disorders in which both parents have to be a carrier, but even if they are a carrier, they may not present the same symptoms as their child may, if they end up getting what we know as a recessive trait, meaning that it hasn't presented in either parent, but it is there on their genetic code. So we do carrier screenings for things like color blindness, because women are much less likely to be colorblind because the colorblind trait is linked on the Y chromosome, but because the Y chromosome is formed from the X chromosome, women can often be carriers for color blindness that would present especially with a male son. So what do we do as nurses in regards to genetics? We have two main goals when it comes to our role in genetics. We assess, so we want to gather a detailed familial history and an exposure history when regarding environmental exposures. When we're doing that familial, we want to think about 2 generations outside of the patient by blood only. So if you think 2 generations out from yourself, you're thinking about your grandparents and their siblings, and that secondary level of a pedigree tree. And then our other role is to refer. We can provide information for genetic testing and genetic counseling, which can be very, very helpful for people to determine if they are likely to pass on a specific disorder to their child that may not be compatible with life. So we can offer information. So our main goal for this, when it comes to genetics for a wonderful average nurse, is to assess and to refer. And that is what I want you to know about genetics as far as nursing goes. Assess, refer, think about when a mutation happens. Has it been there since birth, or did it happen during the lifetime? And those 3 categories in which a genetic disorder may be categorized, which was the single cell, the chromosomal, and the multi-factor. Any questions or comments or needs for clarification, please let me know. Thank you.